Welcome to Health Answers April webinar from ICU to end of life, translating Dexmedetomidine into palliative care. I'm Michelle Moskova and I'm Director of Health Answers. Before we start, I would like to start with acknowledgement of country. I would like to acknowledge traditional custodians of the lands on which we meet today. I'm speaking to you from Darawal land, and Health Answers partners are located across many Aboriginal lands. I would like to pay my respect to elders past, present, and emerging, and extend that respect to all First Nations people here today. Some of you may not be familiar with Health Answers. Health Answers is a collaborative research partnership of 12 organizations. We serve communities across Southeastern New South Wales and ACT and work to support implementation of evidence and improving healthcare and health services across and access to care for all of our communities. This webinar is part of the Health Answers Evidence to Practice series. This series are designed to share practice of how research and quality improvement and any other types of evidence are used to improve healthcare. It's also designed to connect healthcare, academic, community, and policy stakeholders to collaborate on improving health and healthcare delivery. And Charmaine, could I get the next slide, please? It is my pleasure to present today Dr. Benjamin Thomas, and he's a palliative medicine staff specialist and head of services for palliative care at the Illawarra Shoalhaven Local Health District. He's also a senior lecturer in medicine at the University of Wollongong. His research focuses on consciousness and sedation at the end of life and exploring how novel agents can improve comfort, responsiveness, and quality of dying for patients and their families. And alongside his research, Ben leads service development and workforce planning across Illawarra Shoalhaven Local Health District and palliative care. He also teaches medicine and palliative care across postgraduate medical education at the University of Wollongong. And he's also currently completing a PhD by publication at the University of Wollongong, and that's very, very busy schedule, Ben. Over to you, Ben.
Thank you, Michelle and Charmaine as well, and thank you very much for inviting me to take part in this session. So thank you, everyone. Lovely to see some people online whose names I recognise, and also a lot of people who don't. So as has been said, my name is Ben. I'm a palliative medicine specialist. I'm a medical administrator, I'm a lecturer, and I have the fortune of doing a PhD on top of all of those things. So I am, shall we say, a little bit busy around the edges. And when people ask how you manage to do all those things, I say you get very good at juggling until you drop everything and then you have to start over. So this talk is about the novel for palliative care sedative dexmedetomidine, which has been in use in critical care, so intensive care and anaesthetics, for close to 2 decades now. And just the journey that I've gone through utilising this sedative in the palliative care space, which began, I mean, I'll get to it as we go, but kind of began close to 10 years ago now when I was a trainee doctor. I've titled it Translating from ICU to the End of Life because that's been the journey that we've been moving along, although we're starting to expand out of that space, which I'll talk to a little bit as the talk progresses. So we'll go next, please, Charmaine. So just the boring things up front, essentially, is that I don't really have anything exciting to declare. My research for dexmedetomidine has been primarily investigator-initiated and funded by our LHD. Our initial studies were internally funded by our Department of Palliative Care at the time, using volunteer contributions that we regularly receive for our ward. And I received an early career researcher grant in 2020 to continue what became our randomised control trial. So we'll go next. So just by a bit of a way of background, as a palliative care specialist, about 3/4 of my work is looking after patients who are at the end of life. Not all of it, because we actually do a lot outside of that around complex symptom management, bereavement processes, psychological counselling, all of those kind of things. But one of the things that I'm continually confronted with as time goes by is that I think death and dying is becoming less common in the culture in terms of what people are expecting or what they are exposed to. Watching shows like, I used to say Grey's Anatomy, but that's possibly a little bit more dated, although I believe it's still on the air. But maybe The Pit is a little bit more common these days on HBO. But what we see on TV in terms of someone just gently falling asleep while surrounded by loved ones is not always the reality, although we like to believe it is so. Um, and we see clusters of symptoms at the end of life that are often quite challenging to manage. And especially for patients in the palliative care space where we deal with a high malignant population in terms of cancer disease, where in a palliative care ward environment, we might have up to 80 or 90% of patients with a cancer diagnosis. And that predisposes especially to something that we call terminal delirium, which is essentially a hyperactive or mixed delirium at the end of life, where someone is suffering from hallucinations, agitation, changes in consciousness and changes in awareness that leads to hyperarousal and is often very distressing. And this is actually probably one of the most challenging symptoms for us to manage in palliative care, and has traditionally been managed more with sedative mechanisms rather than anything else, because treating the underlying cause, which is often escalating pathology or organ failure, is often either outside of someone's goals of care or is not particularly practical. Next slide, please, Charmaine. So as I've mentioned, we will often give sedatives, and traditionally we've been using a mixed variety of sedatives, which I'll talk a little bit more to in a moment. And I think the challenge with providing sedation for refractory symptoms is we're making a choice around responsiveness and consciousness for patients, which can often be quite confronting for the person if they're able to maintain any level of awareness around that, and for the families. And I've popped a line there around biographical life. And that's a phrase I became exposed to from a professor of palliative medicine called Robert Twycross, who worked at St Christopher's Hospice in the UK until he retired about 20 years ago. And he referred to biographical life as the part of life that we all experience when we are interacting with families and friends and loved ones, and we are making memories. So we are basically forming our biography. Whereas the things that happen when that is artificially taken away from us, when we are sedated for anesthetic or at the end of life, we essentially lose that biographical component to our life. And we may be still living in that we are physically alive, but we're not necessarily having that valuable interaction. We do know in palliative care there've been some studies done, and we've done them in Islip at Port Kembla with bispectral monitoring, that awareness to an extent is preserved, but the actual interaction with loved ones tends to be lost. And that can be a challenge because we know that awareness is valuable. And in a very large study that was done in the early 2000s in America, the most valuable part of dying in terms of symptom control that patients valued is being aware and being able to interact and make memories with their loved ones. Whereas when you survey physicians and nurses and other health staff, we actually tend to value that much less greatly than good pain control. But patients are willing to make that trade, as are families, which is an interesting dichotomy. It's also challenging for us because someone can appear to be comfortable on the outside, whereas we don't really know what's going on the inside. And we're giving sedatives that create an appearance of comfort, but we don't necessarily have the ability to wake someone up and say, are you actually comfortable? And so that creates an inherent challenge in how we practice this medicine. Next slide, please. So midazolam, which I'm sure a lot of people here are familiar with, is a benzodiazepine that we've been using in palliative care since 1988. The actual foundational evidence for that was a letter to the editor of The Lancet, where some very senior palliative care colleagues in the UK reported a case series of using midazolam instead of other sedatives and found that it was effective at a variety of dose ranges. And it provided a decent comparable sedation to the relatively broad spectrum antipsychotics that were typically in use at that time. And most of our foundation evidence was built on that letter to the editor, a few cohort studies and some case controls, but nothing really more robust than that. But that essentially entered our standard of care. Midazolam is, of course, used in much broader fields than just palliative care. We use it for twilight sedation for procedures. We use it for seizure arrests. We use it for anxiolysis. It's penetrated everywhere in medicine, but this is where it came from for us. We do have some limits in our use of midazolam in that the sedation that we provide, we assume to be deep. We do know that patients can get a paradoxical agitation and delirium with midazolam. I actually saw one patient with exactly that problem this morning on my ward round at Bulli Palliative Care, who was hallucinating worse when that patient received benzodiazepines. And so it's something that if we had a better alternative to, we might look elsewhere, especially for patients who, referring back to that concept of biographical life, might still like to make meaning and make memories. Next slide, please. So dexmedetomidine, we'll click through. In terms of dexmedetomidine, so it does a few different things. And these are just a few highlights about what I like about dexmedetomidine and how it manages symptoms. The first point that it puts people in a more natural state of non-dreaming sleep is much better than the actual sedation load that comes with midazolam. So patients who are sleeping with dexmedetomidine and its related drugs like clonidine tend to be a little bit more naturally asleep. The rousability is what actually got me interested in it in the first point, which is that if you get the dose right with dexmedetomidine, you can often go and interrupt someone and wake them up, and they will talk to you, and then they'll fall asleep and drift off again when the stimulus is removed. So you do have that opportunity to interact and create those memories, at least in theory. And so that can be a very valuable experience for someone at the end of life. There is some theoretical analgesic benefits, which are mostly seen outside of the palliative care space, especially for nerve pain related conditions like neuropathic pain. And dexmedetomidine is safer in that it doesn't really have an effect on respiratory rate. It is less safe from a cardiac point of view, although from a palliative care physician perspective, that's not always necessarily a problem. But there are some more tricky things around cardiac monitoring that have always been classically done with dexmedetomidine. Can we move to next? So I'm not going to go too technically into neurophysiology because I don't think that's really a great general talk topic. But this is just a little bit around the receptor targets of the brain and where they work. But essentially what I tend to teach my registrars and what I talk to patients about is that I'm decreasing the stress hormones in the brain, especially when I'm giving dexmedetomidine, with the goal of reducing excitability and reducing irritability and also making them sleep in a natural state. There's a little bit of frontal lobe deactivation, which controls that hallucinogenic potential as well, and that seems to decrease the ability to see those hallucinations. Sorry. Midazolam, whereas it's a benzodiazepine, so more of a GABA butyric acid receptor modulator. And there's GABA receptors pretty much everywhere. And you do get more of an amnestic sedation as well. So if you get the dose of midazolam right, people don't tend to remember what's going on. It is notable for dexmedetomidine that there are actually alpha-2 receptors in many other parts of the body that are not just in the brain and the spinal cord. There's receptors in the salivary glands, there's receptors in the guts, there's receptors in the lungs and in the heart and all over the place. So we actually see other benefits from dexmedetomidine around other symptoms at the end of life, like secretions and nausea and a few things that seem to be added-on benefits. Next slide, please. So in terms of how I first was exposed to this drug, I'd already been working as a junior doctor for a few years, and I was just about to become an advanced trainee in palliative care. So I'd sit my physician exams as a BPT or a medical registrar, and my last run as a medical registrar, I was on night shifts. So I got the joy of closing out the year on nights, and it was just around Christmas time. And I remember I went to a Met call or a rapid response or whatever it might be called where you work. Where we had a patient who was being taken to ICU after being very unwell. And I was chatting with the ICU registrar at the time, and she told me, don't worry, it'll be fine. I'll pop them on Precedex so they're not too deeply sedated, and we'll hopefully get them out of ICU in a few days. And that's distilling a very long and boring conversation. And I'd never heard of Precedex. I mean, hypothetically, I just passed my physician exam, so I thought I knew quite a lot of things realistically, although I was aware I knew a lot of things that, there were a lot of things that I didn't know. And I asked what that was. And this registrar said to me, it's fantastic. It does all of these things. It's a sedative that allows you to still talk to people. You can wean them off rapidly. It provides analgesia. It decreases confusion. And I said, I'm going into palliative care. Why can't I use that? And she said, it's too expensive. You'll never get it. And it's also restricted to ICU. But it's pretty safe, but you'll never get it. She basically said, it's too expensive. Don't even try. And I thought, that sounds silly. I mean, there's a lot of stuff that's very expensive that we do in hospitals and healthcare all the time, and this just sounds a little bit arbitrary. And it was 2 o'clock in the morning, and I had a lot of coffee by this point in time just to stay upright. And I didn't have any more Met calls for the next few hours. So, like everyone does back when you're stuck in a hospital in the middle of the night, I decided to do a journal search rather than scroll Instagram. And so I went looking for palliative care and dexmedetomidine, and I found almost nothing. I found 5 case reports that it had ever been used at all in the world in the previous 15 to 20 years. And I found more than double that in terms of think pieces and opinion about how this drug sounded fantastic and someone should really try to use it in palliative care. And so I thought, well, I mean, I'm somebody. How hard could it be? And that might have been the 3 a.m. by this point talking, because I knew nothing about running clinical trials and studies. But I thought, well, I mean, it can't be that tricky, surely. So after I was off on my night shifts before I started my AT, I went and spoke with my incoming supervisor, and I asked if he'd ever heard of this drug, and he had run into it in ICU once in his past, years of practice, but he'd found it interesting, and that he was willing to find me some money from the departmental budget to pay for its use. So if we can go to the next slide. And so that was at the start of 2018. And this is a trajectory of my next 5 years with this drug. So in 2018, I wrote a protocol for a pilot study for the use of dexmedetomidine for agitated delirium at the end of life, because we thought that sounded like a good idea. I got ethics approval for that November, and we started recruitment. In the meantime, I rotated away to another health district, and my supervisor kept running that study, and we ended up recruiting 22 patients in total. We didn't actually have a recruitment target so much as when we were going to run out of money. We hoped to get about 10 patients. We spent the first $5,000 on the first 6 patients because the drug was incredibly expensive. That ICU registrar was right to warn me. But it also became a generic 6 months into our study, and the cost dropped by 95%. So we were able to do the next 20 patients in the price that it cost us to do the first 5 or 6. So that was phenomenally lucky timing for us, actually. Clonidine I've popped in as a case report because it's also an alpha-2 agonist, and that was suggested to me as it's cheaper, you should try that instead, but it doesn't work as well. So as part of my journey, I did do a case study with clonidine. But you can see that eventually we managed to publish our pilot study, dexmedetomidine for hyperactive delirium at the end of life, in Palliative Medicine in 2021, which is just after I'd become a specialist. We also, along the way, did some admixture testing where we mixed dexmedetomidine with morphine and with a few of our other drugs just to see if it was compatible in a mix with those, because it's administered as an infusion via a syringe pump or a syringe driver. And because we were doing a clinical trial, we were giving it by itself because we wanted to take out any potential compatibility issues. But we also thought if we are going to use this in practice, we would like to know if we can mix it with things. So we did some pH testing and other things that found it was fine. And the results of our study were actually incredibly positive. So we essentially had a 100% initial response rate to starting the drug, but slightly more than 50% of patients rebounded and required titration to our second tier dose within 48 hours. So that was a very promising initial finding for us. And then based on that data and based on some previous data around sedation that my mentor had done, I went back and did kind of a comparison between standard care and between our pilot group, and found there were some interesting signals that were worth exploring as well in RCT, which we had since started to develop. Next slide, please. And so on the back of that, just as we were starting to write up and publish, I applied for $50,000 of research funding. This was in March of 2020. And if anyone else remembers what was happening in March of 2020, it was a really bad time to start designing a multi-site clinical trial. I was working in ISLD and I was finishing my advanced training and applying to be a specialist. We initially planned to run this study in 4 clinical sites across ISLD. One of our wards closed and became a COVID unit. The staff specialist who was working at another hospital went back to Sydney because of COVID issues, and so we lost that hospital. And the third hospital, we had someone else retire. So we ended up doing almost all of this in one hospital, just based on attrition over several years. But basically, we bootstrapped and designed a 1-to-1 RCT of midazolam, our prior standard of care, and of the new drug dexmedetomidine that we'd proven in pilot. It was interesting, as part of this, I went back to the literature and looked around midazolam, and that was when I found out that midazolam had never been before tested in a randomized control trial space in palliative care before. Everything had gone back to that initial case report and led it to the editor I'd mentioned in 1988. So we found ourselves accidentally designing a validation study for our standard of care alongside a test of our novel care at the same time in 2020 to 2021 when we were writing this. Next slide for me. And so every study needs a snappy name. When I put this name together, one of our respiratory physicians or sleep physicians told me it was a silly name because it created non-REM sleep, which is non-dreaming sleep. And I said, well, I can't come up with the non-REM trial, Professor Hart, so it's going to have to stay with dreams. So dexmedetomidine for the reduction of end-of-life agitation and optimized sedation is where it was. And I did have to fish in the middle of optimized to get the M out of that. But so that's what we went with in the end. Next slide, please, Shama. So in the end, we ended up in a single centre in Islip, and to be honest, we actually ended up in 3 hospitals, but that's mostly because our palliative care unit closed halfway through and moved to a second hospital, and we did get 2, I think, patients in our tertiary hospital where we had aimed for 12, and that was realistically around COVID ward closures. It was a non-blended study, and that was mostly due to resourcing. We did not have the ability to hire a trial pharmacist and a trial CNC who were able to blind drugs to us. We pretty much had to do it all on the ward at time. Our power calculation told us that we needed a minimum of 52 patients, 26 per arm, essentially to show a 10% difference in our main outcome, which was the RAS-PAL, which is a 10-point consciousness or responsiveness agitation score. And we were hoping that there would be that difference, or hypothesizing that there would be that difference between the drugs. We also tested everyone's delirium score daily as we went through the study, because that's what we'd done in our pilot, and we wanted to see if that's sustained on our dose protocol. And we also did something called a PCA, which is it's a score sheet that we asked families or carers or whoever else was there that was non-staff to complete, where they rated their loved ones' comfort out of 10. And they also had free text space to write comments and give reasons why they thought they were uncomfortable. So we collected a bit of qualitative data as part of the study too, and that's actually still in the pipeline. We adapted our dosing target from our pilot study. Our pilot was actually a 2-tiered dose where we gave 0.3 and 0.6 mics per kilo per hour of the dexmedetomidine. And for this one, we went for 0.5 flat. And for midazolam, we gave 0.25 milligrams per kilo over 24 hours. We rounded them both to the nearest simple dose to use in the syringe driver, which was nearest milligram for midazolam and nearest 10 micrograms for dexmedetomidine. The midazolam dose, we sort of had to jury rig a little bit. As I mentioned, we didn't really have any literature to fall back on other than what everyone had been doing for the past 30 years. So we went back with reference to anesthetic literature, worked out the rough proportional sedation we were going for, and found out that we were actually bang on in the middle of our standard care anyway with the mathematical calculation. So we were relatively pleased to go with 0.25. We also monitored the breakthrough medications that people were being given. So breakthroughs we typically give for symptoms at the end of life, such as pain, nausea, agitation, etc. So we counted basically the doses of morphine that someone might be getting, not so much the milligrams, but how many times the intervention was given. And it's worth knowing that we also gave dexmedetomidine as its own rescue medication in this. So if someone was on the dexmedetomidine infusion, they got rescue dexmedetomidine if they had extra delirium or agitation. And similar, midazolam got midazolam. Next slide for me, please. This is just a little bit about our demographics, just very broadly. You can see that we actually had a relatively robust filter in terms of who we approached, and that was our main admission criteria to trial was someone who was admitted for end-of-life care on the unit and was accepting of a proportional sedative approach, because we were trying to get these patients into a state where they might be able to interact with their families and loved ones. They also couldn't be delirious on admission, and they couldn't have been admitted for the point of symptom control without end of life being their primary admitting criteria, which actually cut out a huge swath of our patients, because a lot of patients, as I mentioned, are delirious at the end of life when they're admitted. So we kind of had to jump on patients and consent them early, and we tended to pre-consent as if you do deteriorate and you're here for end of life care, would you be interested in randomization, etc. We only had one person knock us back that we approached because they said, no, actually, I don't think I would like to be able to talk to my family. Not quite what they said, but that was basically the outcome, which was fine. And we ended up treating the 52 out of those 59 for our target. We did have a relatively older age. Our youngest patient on trial was in their 40s, and our oldest was just shy of 100, and we had a slight male predominance in a very high cancer population, as you can see. And those are actually quite in keeping with the demographics of our palliative care unit catchment. Next slide, please. So results. We had a negative primary outcome, which I was surprised by, but not that surprised in a sense. We were proportional sedating both patients, and you can see that we basically dropped from a mean RAS of 0 to about -1 to -3. And what that essentially means in practice, a RAS PAL of 0 is essentially what we are all hopefully now, which is we're able to talk and communicate and get about our day. A RAS of +4 means someone is agitated and throwing bricks and is completely unreasonable and confused. A -5 is completely unresponsive to any stimulus. So a -1 is someone who's drowsy and sleepy and can wake up. A -3 is someone who's quite snoozy but can probably stir and mutter a few words and goes back to sleep. So that envelope is actually sort of what we were, if we had set an envelope target, is actually about where we were aiming for. And both drugs hit that target. It was surprising to us that we didn't have a deviation in them, given our previous experience with dexmedetomidine and arousability. But it is also possible that the nature of the tool, where we're using a 10-point average score done at several intervals during a day, was just not delicate enough to show the variances that happen with responsiveness, given that when we've done previous monitoring with bispectral cores, we can see massive spikes in variability over a 24-hour period. That's possibly something we'll explore in the future, but at least on a blunt instrument like the RAS, we were able to see that both were equivalent. Next for me. Delirium, we did see an advantage that was statistically significant for dexmedetomidine on day 1, which was in keeping with what we saw in our previous study. Interestingly, in keeping with our previous study as well, that was lost on day 2, which was about where we had to increase our dexmedetomidine to maintain that delirium benefit. And we specifically did not build that bridge into study 2 because we did not want to leave patients going up tiers in a trial system when we were specifically doing a more focused end-of-life study rather than a delirium-focused study. It's a reasonable criticism to make that we probably should have had a tiered approach because that's more reflective of clinical practice, but we were more interested in the comparison between the arms initially. It is probably notable that from an MDAS score point of view, 13 and above is a moderate to severe delirium and 7 to 12 is a mild delirium. So you can see that no one was severely delirious after the drug started, although the score is a bit hampered by the fact that drops in consciousness are also considered to be decreases in delirium. So it's hard to be 100% sure, especially given the previous RAS shows that people are dropping down into that kind of snoozy state of consciousness. Next for me. It was, however, interesting, and this was borne out as well, that we got more early withdrawal in midazolam. And it was also interesting to note that when we examined the medical record for the reasons for withdrawal, every single patient who was withdrawal on midazolam had a comment around discomfort. We did have some withdrawals on dexmedetomidine day 2, 3, 4, and the majority of those were because families and 1 or 2 patients actually said they thought they should be sleepier. And that was an interesting finding. But the midazolam withdrawals, every single one that we withdrew was because there was a documentation of comfort, either from pain or agitation. So the dose was insufficient to task. And this dose was in keeping with the standard guidelines that are recommended, CEC last days of life, all of those things for starting sedation with midazolam. So that's an interesting finding. Next slide for me, please. In terms of actual completion of the assessments, you can see that there was a definite bifurcation in who did what. So patients, families on the dexmedetomidine arm were more likely to do them. I don't know if we were selling them better, to be honest, because we were all unblinded, or if they were just more interested because it was a novel treatment because no one was blinded to it. We have a higher number of assessments done because of that. So I'm not sure. I can't really explain that easily, but I was gratified to find that a score of 3 out of 10 or lower, because they were scoring 10 out of 10 for distress, both arms maintained a 3 out of 10 the entire time through. So the overall global feeling from families was that their loved ones were comfortable. It was interesting to see that as time went by, that sensation did get better in the dexmedetomidine arm, whereas the midazolam's did seem to stay about the same. That is difficult though, because we had a very high rate of attrition, whereas we went from 26 patients in each arm on day 0 through to less than 10 patients in each arm by day 3. And that's just because in a terminal study, we do tend to lose people very rapidly. So the amount of power that we have to make any of those determinations becomes much more fraught. But it was still an interesting signal to say that was allegedly statistically significant. Next one for me, Charmaine. So this is basically just summarising those 4, that we did see an equivalence in sedation, so our primary outcome was negative, but we did see some interesting things in the secondary outcome, in that the delirium signal that we had seen in our pilot study did seem to be there in the secondary study as well, despite the slight dose difference. So for me, from a practice point of view, that's an interesting amendment to how I practice with delirium at the end of life now. It was also interesting to see the withdrawal rate in the midazolam arm, which might be reflective of the fact that midazolam dosing has just not been geared appropriately in this study, although, as I mentioned, it was geared towards relatively standard protocolized dosing. Next slide for me. In terms of where to after this and some interesting things that we found as the study went through, it was interesting to note that implementing a new agent was a challenge in the study setting, and also became more and is becoming an ongoing challenge as time goes by. I mean, change in healthcare is hard in the best of circumstances, the best of interest, best of cases. I think it's also very hard to challenge the status quo when you're going against a practice that's been in place since 1988 and been relatively universal since the early 90s. It's interesting to possibly flag as a familiarity bias, so that might not be quite fair in my wording, but I know that if people are familiar with the Hawthorne effect, that's basically when you introduce a new practice, people tend to over-monitor it, and so they maybe compensate in the direction of over-egging that particular intervention or that particular role. It's unclear whether the Hawthorne effect is statistically true or not, but it's an interesting way to describe the way that we do tend to be overzealous when we're doing a new thing. So it's hard for me to be sure whether those extra forms, those extra monitoring, some of the things that we're seeing were an example of us doing an unblinded trial with a novel agent that not everyone was familiar with, versus is there actually a discrepancy in what we saw with the midazolam arm? Like, is there a negative or a positive, or is there both? And so that's a challenge for us moving forward. There are some dichotomies that we're seeing in our qualitative synthesis at the moment around family versus staff perceptions around what's settled in the electronic record commentary versus what we actually saw, and the discrepancies that has with breakthrough patterns as well and doses of medication given. So there's a bit of watch this space things coming through, which I'll speak to as well in the next couple of slides. Charmaine. Okay, next again. Got too many title slides in these, sorry guys. So I got to update this slide yesterday because this just got through with the journal, is currently gone out to production. So our second paper after the main trial was published, which was published in the middle of last year. The results were published in the Journal of Pain and Symptom Management. So we've performed a correlation analysis between essentially, if anyone's familiar with PCOC, which is a palliative care outcomes collaboration, it's a relatively universal language and scoring system for palliative care symptoms and severity. One of the things that we do on our unit is we collect scores around how distressed patients are, how much pain they have, how distressed their families are, a few other things. And we essentially went back and matched those symptom severities towards the patterns of breakthroughs. So pain relief, agitation relief, nausea relief, medication for death rate, all those kind of things, that patients in both arms were given, just to see if there was a discernible difference between arm 1 versus arm 2. So did patients in dexmedetomidine, for instance, when they were experiencing more pain, were they given an appropriate level of pain relief, or was it not paid attention to as much? And the same for midazolam. And I haven't included the graph here, I'm unfortunate to say, but I can say that there were some interesting discrepancies in that the dexmedetomidine arm patients showed appropriate levels of breakthrough medication relief for symptom severity in 2 out of 3 of our key domains, whereas the midazolam one showed negative to 0 in all 3. So interestingly enough, the patients on the standard care arm did not get appropriate assessment for did not get appropriate administration of breakthrough medication. And they were all prescribed, they just weren't used. And the difficulty is knowing, were they being used too much Were they just not being assessed the same way? Was there the assumption that they were comfortable because they're on the standard unit, so they didn't require an extra medication? These are all things that we're as yet unsure of, but it was interesting to see a negative signal away in some of those breakthroughs. So that was challenging, and hence my little tag down the bottom: does the familiarity affect the actual breakthrough dose? Because we're just not quite sure exactly what's going on there. But it was something that probably wasn't entirely by coincidence, given it was all three. It wasn't just one domain. Next slide for me. So this is the one that is my next work in progress. So basically, as part of those patient comfort assessment scores I mentioned before, there are quite a few missing, because not everyone did one, of course. We had 82% of families in one arm and 64 in the other, and not everything's as robust as each other. But several families wrote essays and some families wrote single words. But there's quite a lot of very interesting information that we've been given about how families were perceiving their loved ones while they were dying under our care. And to match with that, there's also the same things that we, as staff members looking after their families, medical staff, allied health staff, nursing staff, wrote a lot of our perceptions in the medical record as well, both through ward rounds, standard note templates, but also family meetings. And so at the moment, we're doing a bit of a thematic exploration of both of those things within a predefined framework, just to look to see essentially what is acceptable and what is different, and is it driven by either arm in particular? Are there any differences? So that's probably going to take me quite a while, because I've got about 1,500 electronic notes to go through and about 500 patient forms of various substances, although some of it's numerical, so it'll get excluded. But it will be interesting to kind of bring that back to the other results, and that'll be a little bit of a watch this space down the track. Next slide for me. So this is just, I'm getting close to the end, so I've got plenty of time for questions. But basically, this is all kind of tying into my PhD, as Michelle mentioned at the top, which is essentially around what is effective and what is acceptable in terms of consciousness and sedation at the end of life. So my research has threaded through all of this is essentially around what is called proportional or interactive sedation and lack of delirium. So how can we make the quality of someone's dying phase better, both for them and for their loved ones? Some of my patient comfort forms were filled in by the patient themselves. It was very nice to be able to go in and wake someone up and just ask them how they're feeling and have them fill it in. As a clinician, it is incredibly rewarding to be able to go in and have conversations I didn't think I could have before. And so this is all kind of translating into that PhD by publication. But it is also an interesting challenge, as I mentioned, that earlier study in America around what families and patients think is more important to them in terms of comfort at the end of life, around being able to communicate with one another, versus physicians and nursing staff think it's more important we provide adequate pain relief, to the exclusion of that communication. So who gets to decide is often a bit of a challenging one. Do you want to skip 2 ahead, Charmaine, because the next one's got a title on it, I think. There we go. So a little bit of a summary slide, which I'm not going to read through, but I just want to share 2 or maybe 1 patient experience, and maybe a little bit of a thought. The very first patient that I gave dexmedetomidine to on my pilot study back in 2018, December 2018, February 2019, I was convinced this was never going to work, and it was a complete fool's errand in palliative care. And it was a lovely patient who was starting to hallucinate and was deteriorating on my ward, and was seeing hallucinations of horrible creatures in the corner of the room mocking her, described as devils. Incredibly, incredibly distressed and very unwell. So I started on a dexmedetomidine infusion and gave a loading dose, and I thought, okay, I'll pop back in 3 or 4 hours, which was my protocol at the time, and see how they're doing. And I went back into the room, completely unconscious, and I thought, oh dear. I'm not quite sure how this is going to go, actually. I've spent 9 months putting this all together, and it doesn't look like it's going to work. And I walked in and I touched her on the arm, and she just woke up. And she looked at me and said, "Oh, hi, Dr. Ben." I said, "Oh, yeah, hello. How are you feeling?" She said, "I'm having the most beautiful sleep." Great. How? And I asked her if she was still seeing any of those horrible things. She said, "Oh, no, they've all gone away. They're not bothering anymore. I feel amazing." And her hallucinations were completely gone. And I walked out and I said something slightly rude, but I thought, yes, this is going to work. Maybe this is going to work. Who knows? N equals 1. And that was basically the pattern for the next little while. And one of my colleagues who was a co-investigator on both of those studies said to me that the most rewarding thing about doing it this way is that even if I can't have a conversation with people, I can walk in and ask them, are you comfortable? And they can tell me, yes, I'm okay. Whereas before you just had to walk in the room, look at them and say, I think it looks all right. And that's really the main difference, is that we can get something back. And so we can know rather than guess. So I'll go to the next slide. And this is just a bit about a thank you, because I do need to thank all of my patients and my families that have taken part in this, because without them, it would have been impossible. And to all my nurses that have put up with me imposting so much extra work and harm onto their lives for the past 7 or 8 years. It has been a very big struggle for them all. And they've put up with my foolishness quite a lot. But these days, quite a lot of them actually enjoy using our novel methods. So that's going well. And there's, if anyone really wants to read, there's where we're up to publication-wise in terms of this journey as well. And of course, thank you to Judy and Kylie, who I like to tell them they bullied me into doing a PhD, and that they both took me for coffee and said, you should think about doing a PhD. And I said, I'd have to find some supervisors. They said, we're having a coffee for a reason, Ben. And of course, thank you to Greg and Angela, who've been co-working with me through this whole way, both as a vets trainee and now as colleagues. So that's this talk. And now for questions.
Thank you, Ben. What a wonderful story. We do have time for questions, and please put your questions in a chat, or just put your hand up and we can unmute you. We do have a few questions for you as well. We do collect data on our webinars to be able for us to improve the quality in the future, and also to be able to understand what topics you might be of interest to you. So please scan a QR code, or Charmaine, just put a link in the chat. If you can use that link, that would be great. Okay, we have a few questions. Anthony, you are the first one. Think.
Hi, can you hear me?
Yeah.
Yes.
Perfect.
Yeah, fantastic. So that was a fascinating talk. Thank you so much. So I'm a GP in a regional hospital. I do a lot of palliative care. Have learnt my skills, as most other people have, through being shown by others and various guidelines. If we wanted to start using dexmedetomidine for our end-of-life patients in a regional hospital, how would we get the drug? What sort of protocols should we use? You know, the practicalities of translating your research to a queen bin.
Yep. No, that's
I would love to do that.
Yeah, no, 100%. So this is very much a work in progress, Anthony. So at the moment, so dexmedetomidine within New South Wales, to my understanding, is restricted to intensive care units, critical care units, and one palliative care unit, which is mine. I essentially have a dispensation to use it. But that said, I am in ISLD, just about finishing signing off a protocol for use essentially within hospitals, which we will then move into our community space. So that's happening over the next couple of months. Actually, it's just got signed off by our nurse practice group and needs to go to our drugs and therapeutics committee. It's one of those ones that's going to be probably a bit of it's not a this year thing, if that makes sense, but I'm busy developing a protocol which I think will be adaptable to other settings with appropriate DTC endorsement each place. And I'll be very happy to share that once it's endorsed, if anyone wants to write to me. But essentially it's around dose guidance, monitoring, when to start, when to use. A couple of other palliative care units have also, I've had chats with them and colleagues in New Zealand. So it's starting to pop its head up as our research has been published in Melbourne, in Adelaide, and in Rockhampton, I think. So it's one that is gradually seeping out. It's just going to be a little bit of a slow burn. But if I can get an endorsed New South Wales health policy on the books that shows this is how we do it in ISLD, then I think that might be something you'd be able to take and look at and potentially adapt to your setting, if that makes sense.
Thank you, Anthony. Any other questions? Just while we're waiting for questions, Ben, I love your enthusiasm in 2018. It couldn't be that tricky, right? So looking back, what have you learned about implementation and change?
So I was just about to step into a training program where you have to do a research project, Michelle, as part of the training. And so hence I was sort of on the hunt for a research project, and I thought this doesn't sound too hard. And I must admit, these days when I have advanced trainees talk to me and say, "What should we do?" I say, "Don't run a clinical trial. It's insane. Don't ever do it. It's crazy." I mean, one of the things that I've learned is not that the system is necessarily set up to make us fail. It's just that there's a lot more steps in most processes of setting up research programs and then translating them into practice than you initially think at the start. It's also, I think, very challenging working as a clinician and then as a clinician academic to necessarily know how to navigate those structures. I was very lucky in that I had a research officer at my hospital at the time, and if there are research officers or research staff at your university or in your hospital that can help you do that, that's probably my recommendation, is lean heavily if they will let you lean, because I didn't know what a site-specific authority was when I started. I'm still not entirely sure that I do, but I've had to do a lot of them. I didn't know how to do a HRIA or a Regis application. I do now. I don't like doing them, but there's so much nitty-gritty process things along the way. And I think that the more that you can engage with all of those process things, because having the idea is fantastic, but there is so much that needs to be done between having the idea and getting to then take that idea and play with it. And I think that also speaks a little bit towards Anthony's question before about it's a wonderful thing to do. There's just a lot of steps in the middle to get there, and hopefully having shortcuts in the way where people have done that before makes things. The short answer is never be first to do something. Always lean on what someone else has done.
Okay. Good advice. If we looked at where to from now, you said that you're looking at community settings, and I know
Yes.
we have end-of-life care in many facilities, including aged care facilities. How likely do you think it's going to be practical to apply it in those settings?
I think aged care is going to be challenging, to be honest, if only because accessing the medication is going to be very difficult. For us, giving it in a community palliative care space, we're able to dispense from the local hospital, and it is relatively affordable. However, I'm not quite sure how easy that would be to go through a aged care aged care facilities formulary and get it from their local community pharmacy. I must admit, I have not checked. The backup to that, where I mentioned that I did my case report on clonidine, which is cheaper. There is a lot of research coming out of the UK, which I have leaned on as well, for the use of clonidine in these settings. If I can refer everyone who is interesting to Paul Howard, who's written a couple of excellent articles from the Isle of Wight. He's a palliative care consultant on using clonidine in these settings. And he and I have communicated a bit over the past few years, but essentially he couldn't get dexmedetomidine because it was not subsidized by NICE. So I find that clonidine is better for analgesia, not as good for sedation, but I do use it as well. It's not as restricted. It's much easier to get. General pharmacies can order it in the community, and it can be given in nursing homes, and I have done so within ISLED. So that might be an option as well. And there was an excellent article in BMJ Supportive and Palliative Care, I think 2 years ago, where he talked about his dosing and what he uses and how he's used it before. So if people would like to try one of these medications with some good dose guidance, it's either in their palliative care formula in the UK or in that article, that might be a place to start while waiting for Dexmed to get a bit further along the pipeline.
We have a few comments, not really questions, but comments mostly thanking you for the presentation, and also thank you for being the first to do this.
Thank you to Erica. Thank you, Erica. I just turned on the chat. Yes, it's I think back in 2017, 2018, I would have told you I wasn't going to be a researcher, but there you go.
Okay, that's all we have time for today. Thank you everyone for coming, and thank you for your questions, and thank you, Ben, for great presentation. Our
Nice,
next webinar is a panel discussion, and that will be in mid-May. We're talking about implementation science in clinical practice. We will be sending an invitation through our mailing list shortly, so watch out for that if you're interested in the topic. Thank you again. Ben, I'll ask you to just hang on for a bit, and for everyone else, have a lovely day.
Thank you again.